Hello and welcome everyone. This is Caleb from the Tasc team at the National Rural Health Resource Center. Today is August 23rd, and this is our August Tasc 90 webinar, where we will discuss the findings from the 2018 Financial Summit, as well as the updates and expansion of the Critical Access Hospital Finance Manual, Finance 101 Manual, where we expanded and updated measures based on the findings from the 2018 Financial Summit findings. First, we will go through some updates from the Tasc team, as well as from some of our partner organizations, the Federal Office of Rural Health Policy, ARCITA, and the Flex Monitoring team. And then we will hear from Terry Hill. He'll walk us through some of the Financial Summit findings, as well as the some of the previous iterations of the Financial Summit meetings. And then Ralph Llewellyn from Eide Bailly will discuss some of the expansion of the manual, and we should have plenty of time for discussion and questions. We also have Jack King and John Barnes as Flex coordinators will be joining us to discuss some of the implications and the benefits that they see for the new additional measures in the Flex program. So with that, some of the things that are coming up from the Tasc team are, one is this manual, the expanded and updated Critical Access Hospital Finance Manual. We've expanded it to be relevant to small rural hospitals and rural health clinics, so that'll be exciting and beneficial for you guys as you expand your reach, in quotes, from the Flex team to be able to speak to those other providers of care. What else am I just had a, hold on just one second. What else are we doing? Oh, Flex profiles. We will be asking you guys to update your Flex profiles earlier this year to have them updated before the release of the Flex guidance. So early September, so a couple, 2-3 weeks, be looking for emails and notifications and requests to update your Flex profile on the website. We are also in the midst of updating the HCAP vendor directory, so be looking for that soon. And Shannon has sent out a couple notices that CMS is looking for some feedback, let me try and find the notice here. Shannon, do you have that off the top of your head?
Yeah, so CMS is looking for people for a listening session. I just resent, or will be resending tomorrow morning, another call for submission. So please, if you haven't already, you are also able to self-nominate, so don't hesitate to email me and add yourself to the list. Again, I'll be sending out another email reminder about that tomorrow, and submissions are due by close of business on Tuesday, August 28th.
Thank you very much. And I'm also, so the last Tasc update is I'm preparing for the September Virtual Knowledge Group webinar, and the thought or plan is to have that focused on PIMS, on the Performance Improvement Measurement System, for the Federal Office of Rural Health Policy, which your data should be open. It'll be open shortly for you to submit and enter your data. So any Flex programs who are utilizing that data to help inform their activities or programs or projects or processes within their office, please reach out to me. I'd like to chat with you about how you're doing that, or anybody who's utilizing that or found a good process or system to mitigate the the reporting burden at the end of the year. If you're able to put that into a spreadsheet or an Excel document throughout the year, that way when PIM time comes, you're able to just open it up, dump that data in, and be done. I'd really like to chat with you and see if we can share that best practice in quotes with other Flex programs. So please let me know if you're working on some things surrounding PIMs in your office. If there aren't any questions about the Tasc updates, I will ask if Joaquina and or Sarah are on the line.
Hi, Caleb. This is Joaquina. I am on the line.
Hey, Joaquina. How are you today?
I am well, and I guess I'll just kick it off and then turn it over to, or do you have, this is Sarah stuff? Well, maybe I can turn it over to Sarah now, and she can give her updates, and then I'll follow with my policy updates.
Sounds good, Joaquina. Since looks like my slide was the one that was pulled up first.
Yes.
Hi, everyone. This is Sarah Young. Of course, I'm the program coordinator for the Flex grant, and I just wanted to take this opportunity with you today to remind you to carefully read the email that Christy Martinson sent yesterday to the Flex programs and the rest of our State Office of Rural Health partners to just give you a heads up on some of the timelines that are coming up this fall and winter, because we know that you definitely put a lot of work into some of those grant writings, and we want you to have as much planning time as you can. So this slide just is a quick reminder of the timelines that had more detail in Christy's email yesterday. If you have questions about what is coming up in any of these grant programs, please do reach out to your project officer or to me, and we will try to address your questions. So that was the important calendar thing I wanted to bring to everyone's attention. A couple other reminders. Hopefully you all already have the save the date for next week, next Thursday, so a week from today. I will be doing a brief webinar just reviewing the reporting process for PIMS. So Caleb's working on a conversation that includes how do we use the data. The webinar next week will be just really the nuts and bolts of how do you log into the system and appropriately enter your annual PIMS data. And of course, the PIMS reporting system will open up on September 1st. Another thing I wanted to just bring everyone's attention is I hope you saw the email message I sent to the Flex mailing list earlier today. Unfortunately, we did learn from our colleagues in grants that the notices of award for Flex may end up being delayed after August 31st this year. I just wanted to give everyone a heads up about that in case it is going to cause any serious concerns or hardships for your program management. If so, reach out to me and I will try to help. But to just also let you know that even if it's after August 31st, your Flex notices of award for FY18 funding are in process, and you will get them. It just might be a little bit late, and I'm really sorry about the delay. And then the last thing I wanted to point out was I hope you get the research brief updates from the Rural Health Research Gateway, because the University of North Carolina just published a research brief from their Rural Health Research Center on rural hospital mergers. And given that some Flex states deal with a lot of hospitals that are part of hospital systems now, that might be a very interesting research brief for some of you. And those were all my updates.
Thank you, Sarah. And Joaquina, are you still around?
I am still here and ready to give my update. I know I have quite a few updates since we last met and talked, but I'll try to be as brief as possible and respect the time limit for the agenda. So while my slides are being pulled up, the first thing I'll note is the fiscal year 2019 inpatient prospective payment system was actually finalized. That's a final rule, not a proposed rule as I have here on my slides. And the effective date for that rule would be October 1st, 2018. The only thing I wanted to note for your attention, and you'll note through my update in general, that I'll talk a little bit about some policies that are not directly applicable to critical access hospitals, but for which I think would be of still interest to you and for your knowledge. So going back to the fiscal year IPPS final rule, they did finalize extending the Medicare Dependent Hospital Program and Low Volume Hospital Adjustment Program per the 2018 Bipartisan Budget Act. Without now for comment, several rules out for comment that you should be aware of. First is the calendar year 2019 outpatient prospective payment system proposed rule, and a couple of things to note for that. First, they're actually changing the payment rate for clinic visits at accepted off-campus provider-based departments from the OPPS rate to the physician fee schedule rate. So if you may recall, in past rulemaking, CMS is going forward with doing what they call site-neutral payments, whereas they're trying to somewhat equalize the payments that are paid to these provider-based departments affiliated with hospitals, with that they would pay, say, to physician offices under the physician fee schedule, and this is more so out of concern that they were paying for services, higher rate for services at a hospital provider-based department. Those same services will be paid at a higher rate than a physician office under a physician fee schedule. So they're moving forward with that. They first proposed that these many of the off-campus provider-based departments that were in existence prior to, say, November 2015, there weren't going to be any changes made to their payment rates, but now in this year's rulemaking, they're slowly really changing that, and now looking to at least change the payment rate for the clinic visits that occur in these off-campus provider-based departments. They're also looking at doing a further payment reduction for 340B drugs acquired from the non-accepted. So the term non-accepted means those off-campus provider-based departments that weren't grandfathered into or accepted from, I guess you could say, non-grandfathered, in which their payments were affected since about last year, since the calendar year 2018 OPPS proposed rule. And so now what they're doing is actually looking at changing, again, the payments for 340B drugs. Another thing I wanted to bring to your attention is that CMS is looking to try to identify the services furnished in these off-campus provider-based departments. So they're asking hospitals to put a new code, like a new modifier, to better do tracking of these services. And again, these three policies that I just kind of briefly discussed are not applicable to COS. The next bullet is applicable. They're looking to remove 3 HCAPs, so that's the Hospital Consumer Assessment of Healthcare Providers and System Survey, 3 items related to communication about pain, and according to the CMS, is in response to recommendations from the President's Commission on Combating Drug Addiction and the Opioid Crisis, and they're doing it out of an abundance of caution and to avoid any potential unintended consequences of possible opioid overprescribing. Also attached to this proposed rule is the opportunity to provide feedback on promoting health IT and EHR systems interoperability. Moving on to the next slide, also out for comment is the calendar year 2019 physician fee schedule. There's the opportunity to comment on it by September 10th. A couple of things to note. One, major changes to how they're going to pay for evaluation and management services. So they're streamlining coding or the payment and the coding for these services. And instead of having separate payments for levels 2 through 5, what they're doing is going to have a new single blended payment rate for new and established patients. We see this as a possible good thing for rural providers. Our understanding is that rural providers tend to code at the lower levels even when they see more complicated patients. And so, again, that's just one perspective, but then we've heard other perspectives as well, too, related to this. This does not apply to the, one of the things I did want to clarify, because CMS did have a good webinar about this yesterday, too, is that for your non-physician providers, so your PAs and your NPs, that the policy that applies to them where they will still just get 85% of the physician fee schedule rate will still be in effect. So even with this blended payment rate, that policy will still apply. The other fairly big proposal in this year's proposed rule is that CMS is proposing 2 new codes for delivering care, virtual care. They do not see these codes as telehealth, and these codes are not viewed as telehealth. And rural health clinics and FQACs, while they can bill for these codes, again, this is not telehealth, so it's not changing anything under 1834M. So what they're allowing for is payment for virtual check-in, where the patient may do a brief call with the provider to see if they need to come into the office or not, or remote evaluation of video, recorded video, so kind of like your store and forward. In RACs and FQACs, they'll be able to bill for these services, but instead of having 2 separate codes, it'll just be 1 code that will be the average payment of those 2 codes under the physician fee schedule. And if that brief communication results in an actual RAC or FQAC visit, then that higher payment rate that they get, the all-inclusive rate for RACs and the PPS rate for FQACs, would be paid, and not the separate payment code for either of these services here. For the next slide, they actually made changes to telehealth. They added 2 new HCPCS codes for prolonged preventive services, and they've also made some changes to telehealth services per the Bipartisan Budget Act, and allowing certain clinical assessments for beneficiaries receiving home dialysis for ESRD, and removing the restrictions on the geographic locations and types of originating sites for acute stroke. Another thing they're doing is soliciting comments on creating a bundled episode of care for management and counseling treatments for substance use disorder. For the quality payment program, again, this was one big rule with physician fee schedule and quality payment program added to it. I noted that they made a couple of changes in terms of expanding the eligibility for who participates in it. So now you'll have physical therapists, occupational therapists, clinical social worker, clinical psychologists will be eligible starting in 2019. And they also made some changes to the performance category. Most notably, the cost category will increase from 10% of the overall MIPS score to 15% of the overall MIPS score. And finally, another big thing that CMS just put out is the proposed rule for the Medicare Shared Savings Program Accountable Care Organization. And so currently there are several tracks in the Shared Savings Program, or several tracks for ACOs. Track 1 is the track, as you know, that has no one-sided risk, so no payment due back to CMS. Track 1 Plus was something that was proposed through the QPP program, whereas there was some downside risk or two-sided risk, but not as much as, say, level Track 2 or Track 3. What CMS is proposing is a quicker path from this one-sided model to a two-sided model, whereas now ACOs can remain in a one-sided model for almost up to 6 years. They're looking to reduce that to only 2 years over time. And so what they have is two tracks, a basic track that will allow ACO to operate within the downside risk for 2.5 years before they kind of gradually take on risk. And then they have this enhanced track where those are for those ACOs that are already performing in a high-level track currently, like your Track 3, and from the beginning of the participation of the program will be in a downside risk model. A positive thing that CMS is doing in this proposed rule is expanding the waiver for the SNF 3-day rule, so ACOs in both tracks will be able to use the SNF waiver, and the waiver rule will be expanded to include cost swing beds. So I will stop right there. I know those are a lot of updates, and as you kind of think through this, and if you have any further questions, please do not hesitate to send me an email directly. I need to put my email up here, but my email is wscott@hrsa.gov, or you can send an email to the Rural Policy email inbox, which is on your screen. Thank you.
Thank you, Joaquina. Thank you, Sarah, for your updates. We do have one question in the chat box for Joaquina. Do you know when Flex coordinators will be getting notification to have hospitals re-enroll in the 340B program?
Hi, Nicole. Great question. I am going to say soon. I think this is around the time of year where we start getting notice. So I will say that process should begin fairly soon. You're right. It has historically been in August. But I think last year there were some delays, and I won't be surprised if this year there be some delays in them moving forward with the timeline for getting hospitals recertified for the 340B program. Okay, Jill said that the deadline was September 12th. So we'll look into that. If there are any updates, we'll be sure to communicate that to the Flex coordinators and share that information with Sarah as well.
Any other questions for our FOHP representative? Hearing none, we will go to Laura Grenard-Johnson from Arquita.
Hi, Caleb. Thanks, everyone. I just have a few brief updates. And I think those of you that were on the VKG call we had several weeks ago, the MVQIP VKG, this will be fairly familiar. But if you go to the next slide, I'll walk through them here. So recently released and updated, we have a couple of new resources. One of them is the MVQIP Fundamentals Guide for State Flex Programs. And what this does is outlines the current status and history of MVQIP. It's sort of a crash course in MVQIP oriented for Flex programs. Most of the contents there are actually not completely new. They've just been repackaged into a new format that's a little easier to navigate. So look to that if you haven't already. And then the second recently released and updated resource here is the Critical Access Hospital ECQM resource list. This is continually updated. It contains a lot of resources for critical access hospitals looking to meet reporting requirements for EHR reporting and the Promoting Interoperability program. It includes a lot of updates from CMS that are fairly helpful, but because those updates come out frequently, we suggest if you send this to your critical access hospitals to use the link rather than attaching it directly so that they know they're using the most recent of those versions. We have a handful of in-process updates happening. We'll be doing a refresh of the MD frequently asked questions to reorganize those. The Understanding MDQIP Data Reports resource, which is oriented for critical access hospitals, is nearly finished. That just has some updates to the reports that were reflected recently, such as antibiotic stewardship. For those of you that might have had hospitals participating in the Abstracting for Accuracy pilot, we'll be doing a summary about that. That'll be coming out here in the next month or so. What that was a validation pilot for 15 critical access hospitals that opted in to have their abstractions that they submit to CMS validated against Robin Carlson here. And then they had a call with her to talk through any lessons learned or suggestions she had to improve the accuracy of their abstraction moving forward. So we'll have a lessons learned summary document coming out with that, and then we will be redoing or reoffering the Abstracting for Accuracy program in the next coming year. So starting September, you can watch for instructions on how to promote that with your critical access hospitals. But if it's something you'd like to mention to hospitals or keep in mind as an offering for them, just know that that will be being offered again. One thing that's not on here, we just got it finalized, is that we'll be doing an office hours for critical access hospitals on October 10th. That's something we've offered for the past year and a half or so that happens before reporting deadline. So the reporting deadline is November 1st and 15th for CMS reporting. It's an opportunity for hospitals to ask questions of Robin. More details on that are in the MDQIP monthly email that came out yesterday. And then finally, just a reminder that our team is available for orientations or presentations and consults if you have questions or needs. So feel free to contact Jody Winters on our team if that's of interest for you. And if you could go to the next slide. We just have a couple upcoming, and actually one of these is already ongoing requests. Those of you probably seen that we've sent out a request on Tuesday for our annual assessment. This is something, this will be our third annual assessment, and we're asking for feedback from each state. We ask that if you have subcontractors or partners that work on MDQIP alongside you, that you work with them to complete one for each state and ensure that your answers are in alignment. As of this morning, there were 5 states that had responded, so thank you to those of you that have already submitted. If you could offer your response by Tuesday, September 4th, we'd really appreciate it. And then just an advance heads up, this has been shared, I think, at the River site visit, but we'll be doing one-on-one state flex program calls here in the coming months. So Jody Winters, again, here from our office, will be reaching out to set those up. You can expect emails with more details in the next week or two with that. We'll be asking to have a call with each state, and we'll leave it up to you to determine who you want to have on the call. And then the final slide is just a note. We have one more MDQIP VKG for this upcoming 2018 year, and that'll be November 1st. We'll be restarting those and refreshing them in 2019. But in the meantime, November 1st is the first date. For the first time, we're offering a way to register for that. It's not required, but if you'd like to get it on your calendar, you can check in the email sent out earlier this week about how to register. So that's all I've got. If there's any questions, I'd be happy to take them.
Great. Thank you, Laura. Any questions for the Arquita team? Hearing none, we'll go to the Flex monitoring team, and we have John Gale listed as our representative. John, are you there? *2 will unmute your line. Not seeing John in our people logged into the website. Are there any other Flex monitoring representatives on the line who would like to, who are able to provide some Flex monitoring team updates if John's not able to join us? one. I felt like I heard someone unmuting their line.
Hi, Caleb. This is Joaquina. Can I just jump in real quick as a follow-up to my earlier update and to Nicole's question, if possible? I just double-checked, and the actual recertification period for hospitals is August 15th through September 12th. And HRSA OPA had a webinar on August 8th. So usually what they'll start doing as we get to the countdown of September 12th is start giving us updates as to how many CAS and other hospitals have not recertified yet per the deadline. And once we start getting those updates, I'll be sure to share that with Sarah so she can share that with the coordinators as well. Thank you.
Sure. Thank you, Brenda. All right, so as we give Flex Monitoring Team folks one last call before moving into our discussion on our Financial Summit findings and expansion of the Critical Access Hospital Finance 101 manual, please take a moment to complete the polling questions so we are able to assess the efficacy of our webinars. Once you guys have had a moment or an opportunity to complete the polling questions, we'll pull up our slides for the day, and Terry Hill will talk us through some of the previous Financial Summit findings, as well as talk a little bit about the one from this year in May. I will draw people's attention to the chat box where Sarah posted a link to the webinar recording that Joaquina was referencing, and we'll be sure to send that out to everyone so they have an opportunity to view that, as well as post it on the website as a resource for 340B participants. All right, Mr. Hill, are you ready?
Okay, I am all set, yes, and this is our center's purpose. Everybody's seen that. Next slide. So basically, we're going to be talking today about two what I think are fairly important initiatives that Tasc has undertaken, again, with the support of our state flex programs. The first is going to be the 2018 Financial Summit, which was a follow-up to our 2012 Financial Summit, and I'll talk about that in just a little while. And then we're going to talk about the results of that Financial Summit and perhaps hear from Jack and John with some perspectives from both a hospital association and a state office person. And Jack, of course, is the coordinator for the state of Montana as well, and John, as everybody knows, is from Michigan as well. And then they're going to go into more depth. That Ralph Llewellyn is here from Ide Bailey, somebody that we have worked with over the years, one of our go-to resource people. And we asked Ralph to work with us about updating our manual, our Finance 101 manual. Now, both our Summit Report and our Finance 101 manual are probably two resources that are the most downloaded on our center website, not just Tasc, but the center in general. So we're going to talk about that. Ralph's going to talk about the changes. We have included rural health clinics for the first time here. And what you're going to see is an expansion of Flex program is doing more work in the rural health clinic area as we're moving forward here in the next few program years, and then talk about some tools and resources that support rural hospitals for financial success. And again, this is all supported by the Federal Office of Rural Health Policy, and the purpose was as we move from 2012 to 2018, I think we all know we're moving into a different type of a payment system that is basically models like accountable care organizations that are basically springing up all over the country. Not at first they were kind of confined to urban areas that often would take their rural hospitals along with them as a part of a larger healthcare system. But now we're seeing more and more rural hospitals included in these accountable care organizations, and we're starting to identify critical success factors that would enable a rural ACO to be successful. And so we felt that it was time to look at our financial indicators again and see if there were any additional indicators that could be associated with financial performance. Now, you're going to see, I'm going to go over the 2012 indicators, and you're going to see those are really very much just financially. They're pretty traditional financial indicators. And when we look at indicators, we have basically two different kinds of indicators. There are lead indicators and lag indicators. So that's part of the premise of why we wanted to look at this. So lag indicators are all the traditional financial information. It's extremely important, but it's always looking behind us and saying, hey, how did we do last quarter? What did last month's financials look like? And basically the recommendations coming out now, not only from the ACOs, but from Harvard Business School, from our medical schools, public health, et cetera, is that we need to be looking at other types of indicators as well that could be associated with financial success in the future. So having good financial numbers in the traditional sense as a critical access hospital does not necessarily mean, or certainly not guarantee, that you're going to be successful in a very different type of payment system if you choose to move into an accountable care organization, or if, like in the case of Pennsylvania, you become part of a global, we have a number of rural hospitals that are part of kind of a global budget system, et cetera, that is being paid for to the rural hospitals in Pennsylvania. That we had the same system in Maryland, for example. So what we've come up with is a kind of a list of kind of non-traditional financial indicators that we'd like you to consider. And in order to do this, as we usually do, and we've been doing this for about a dozen years at least, we brought together a group of participants from various types of backgrounds, profession, et cetera. And this is the picture of the 2018 summit participants. It took place on the 22nd and 23rd of May, 2018. And it's taken us this amount of time. Actually, we put it on a relatively fast track to get it available to you. You're going to be getting this within the next few days. Next slide. And these are the folks that participated. Again, I've mentioned John already from the Michigan State Office of Rural Health. And we thought that John's participation was especially important because he's been managing two accountable care organizations very successfully in Michigan. And so we really wanted to make sure that we had his input. Steve Barnett is a hospital administrator from McKinsey Health System. Some of you might have seen him. He was one of the presenters at our reverse site visit. great hospital administrator. We wanted to make sure to get a hospital administrator input. Brian Bursch is with Ide Bailey, so we wanted to make sure that we had at least 3 or 4 big financial agencies there that do a whole lot of work with rural hospitals and also have a background and an understanding of the new ACO and value-based payment system. Jane Jerzak was from Whipley, again, another consulting organization, and Whipley does a lot of work on the West Coast, and some of you may be familiar with them. Jack King kind of represented both the Flex program and is a Flex coordinator, but also with the Montana Hospital Association, so we wanted that perspective. Janine Myers and Sarah Young both participated as representatives of the federal office. We had Jonathan Pantenberg, who represented Stroudwater Associates, and we wanted to make sure we had somebody from the Flex monitoring team. So Christian Ryder represented the University of North Carolina. Many of you may know Tim Size, but he has the, I think his healthcare network, which includes, 30 to 40 rural hospitals in Wisconsin, has been around since 1979. So Tim also operated a rural HMO years ago, so he's got a vast background here. And finally, Carla Wang represented rural health value to make sure that input was given as well. So we just put our favorite slide up here. It's about cost, it's about health, and it's about better care in general. That's obviously smarter, better care, smarter spending, and healthier people. Now, these are some of this is from 2012, and some of you have seen this already. It's still included in our Finance 101 manual, but in 2012, we brought a similar group together, and we asked them to identify what are the 9 or 10 most important financial measures. For those of you, I think most of you have seen these before, but even though we get a ton of information, a lot of really good information at the University of North Carolina, who, by the way, participated in this particular summit meeting, these were the ones that they thought to be most important. Days in accounts receivable, days cash on hand, total margin, operating margin, long-term debt to capitalization, debt service coverage, salaries to net patient revenue, Medicare inpatient payer mix, and average age of plant. So those have been the traditional indicators. We ran them first as one of our first things past our group, saying, okay, are these indicators still important? Can we tell the Flex programs to continue to look here? And again, I think this has partially due to the fact that we're still getting paid if you're a critical access hospital under the old system, and these are still very important. So we got a confirmation of everybody that these were still super important, and then we had them come up with a couple of additional financial measures as well. Now, next slide is this is going to be what you're going to be getting here very shortly, and we have generated a number of different indicators, and we broke them down. These are kind of the categories that you're going to be seeing some of these new indicators. So if we look at the market indicators, what we're suggesting, and as I said, you're going to get them very shortly, is that market share becomes extremely important. We have got to, if we have fewer people in our beds, we've got to make up for it with greater volume. So we need to stop that out-migration for care, and we need to basically measure this. And it becomes something very critical to our value-based formula. Now, within the report will also be some basic strategies that will suggest how to improve the market share, et cetera. Not a lot, but just we wanted to give you some ideas about that as well. Another one that came in that was out-migration rates. That, you know, this is one to consider. It doesn't mean, and this does not mean the flex programs have to use all of these, but they may be indicators that you'd want to let your hospitals know. They may want to think about tracking if they have any plans of moving into value or population health. Another one is patient mix. And finally, under marketing or market share was attributed lives. How many lives are attributed to this particular accountable care organization? How many are each of the hospitals bringing? In the area of financial performance, there's a couple of other ones. I'm not going to go into that. Under operational efficiency, one of the ones that came up was average cost per clinic visit. So you see we're starting to put in clinic indicators here as being important. That has some financial implications, looking at salaries to net revenue, and then looking at minimum productivity standards for clinics, for hospitals, et cetera. So we're starting to get into some efficiency measures here that our summit group is suggesting are important to look at and you might want to consider as if you're a hospital moving into value. Under workforce, provider and staff engagement becomes really important, as does the number of primary care physicians. And one of the things that we're working on a project, the center is working on a project in the Mississippi Delta right now, and we're working with all the participating hospitals on developing staff satisfaction scores, because we know that staff satisfaction scores are very directly correlated with patient satisfaction scores, and the kind of the exodus of people. We're losing our nurses, we're losing our physicians, et cetera. It has very direct financial implications here, and so we need to be thinking about that. And again, we're seeing this expanding number of indicators, all because we're moving into this new payment system. Under quality performance, HCAHPS becomes something we should be tracking for the very reason I talked about, because patient satisfaction, again, is calculated into the formula for accountable care organizations under those quality guidelines. And although we don't have them all listed here, quality scores in general, there's ACO quality scores. MBQIP is relevant, although we didn't single that out. But MBQIP becomes something important in terms of proving our value and in terms of getting paid as we move down the road, as does, as I indicated, the ACO, which have an entirely different set of quality indicators. Some of them are in MBQIP, some are not. In the ACO quality indicators, 11 of them are wellness and prevention based, which basically means one of the things we're suggesting here is we need to be doing more wellness visits. Every hospital should be doing wellness visits on every single Medicare patient or recipient, whether they're sick or not. We should be doing wellness visits. We're going to hit our quality standards. We're going to position ourselves to be good financially in the future. Under care management, we have behavioral and mental health screening. What we're finding is that the behavioral and mental health screening basically is directly correlated to ACO financial success. It is basically one of the major financial problems for ACOs, rural and urban, is the huge number of patients who have mental illness or behavioral problems, and they're basically making frequent appearances at our emergency room. It's extremely costly, and it undermines our quality as well. I already mentioned wellness visits. And then we're suggesting, now listen to this, and under community health, that instead of the traditional in-hospital measures or financial measures or other things, that we should be starting to build in some public health measures here and community health measures. So our public health data is extremely relevant. If we're having problems with diabetes rates, and public health, county public health information becomes really important. It doesn't mean we have to deal with it all, but perhaps there's a particular issue we want to deal with, and that's going to monitor our progress over time, those rates. I know it takes time, but it's something we need to be looking at. Our HCC codes, so HCC codes basically gives Medicare and the payers an indication of how sick our patients are. And so we're suggesting we should be looking at those HCC codes because the information that CMS is getting is that rural patients are a lot healthier than urban patients. And the reason they're saying that is because we're undercoding on our HCC codes, and that's directly related to our financial reimbursements. So if we tell the government we have really healthy people out there, we're not going to be able to make the kind of improvements that will get rewarded financially when we look at the end of the year savings or the quality savings either. And then another indicator there could be PCPs with contracts that have specific population health incentives in them. One of our members said this is really important. We have to start building that into the contracts with our providers as well. So those are a couple of the, kind of, you will be getting this information. We really don't have time to go into it in any great detail here. I did want to get at least both Jack and John's perspectives here on kind of this movement and the need for additional indicators. So Jack, if it's *2 to unmute your phone, would you care to comment and just talk a little bit about your experience with this summit and what you think is maybe some of the value here? We know Jack's on. *2. Yeah. Well, I'll give Jack some time to jump in here. How about John? John Barnes, are you on?
Terry, this is Jack.
Hey, Jack. Thanks.
I'm sorry, I was double muted here, and it took me a minute to figure that out. Yeah, you did a great job, and I would encourage everybody to pay close attention to the report when it comes out. We've been, those of us that were at the summit have had it in our hands for a number of weeks now, but I'm really looking forward to getting it out to all of our hospitals, and we'll be doing that at our annual convention coming up next month. But without going into too much detail, and I know that I certainly took a lot more away from the summit experience than I brought to it. I'm pretty sure of that. But I think the two most important parts of these new indicators are that they're lead indicators as opposed to lag, and you mentioned that. And it allows hospital staff and leaders to look forward and be able to prepare for the things that are coming down and determine the types of investments that they need to make in various resources and tools, anywhere from staffing and providers to community situations and those kinds of things. And for us here in Montana, where we have 40 48 critical access hospitals that go anywhere from, extremely tiny, very low volume operations to, some of the larger critical access hospitals. With these new sets of indicators combined with the original 101 indicators, there's something for everybody here, even a really small organization that's probably quite a ways from being able to prove, being able to prove enough value to take part in an ACO. They can go through these additional indicators and be able to apply, look at their own operations and make adjustments and make changes and learn a lot more about their environment and their market and the things they're going to have to do to prepare. So I'm pretty excited to get this information out to our hospitals, and I think it's really going to allow everybody to have a bigger picture than just the top 10.
Yeah, I appreciate that, Jack, and specifically, Jack pretty often kind of challenge us to make sure he has the smallest little hospitals. They're so isolated. We have similar situations, particularly in the western part of this country, and so we need to make this value-based payment and population health work for our smallest communities and particularly our frontier areas as well. So I appreciated you being there, kind of wearing two hats as both the Flex coordinator and kind of representing the Hospital Association and hospitals in general. I think John had warned us that he had another obligation and he would be coming in late. So, again, I really want to express my appreciation to the members of our summit panel. We will be getting this information out to you very shortly, and what we would ask you to do is, with the information, I think we'll send out just some basic questions to get your feedback. Do you have questions about it? Is this going to be relevant? Might you have difficulties getting this circulated? Just anything else you'd like to suggest. And then a second question would be, are you aware of resources or examples in your state where, something they've built up indicators or information in this regard? So we'd like to build up more of a library of resources kind of surrounding each of the indicators in each of these areas as well. So that's really all I had to say. Again, thank you. We would greatly appreciate, once we get this in place, if this and the Finance 101 manual, if you folks will help us get this out to rural hospitals. I know that some of them are going to find it very, very useful, hopefully most, and we really appreciate any help you can give us. So with that, I'm going to turn it over back to Caleb, and he's going to introduce Ralph and continue our discussion. By the way, these indicators are incorporated into this next document we're going to be talking about.
Yeah, so thank you very much, Terry, and thank you, Jack, for providing some of that feedback. And I want to address Stephanie's question in the chat box about whether or not these measures or indicators will be present in COMPASS and whether or not the data will be there for your guys' review as well as the hospitals. And not currently. A lot of these measures we identified that day at the meeting, so we don't yet have data sources identified and or data to review to put into things, but that is something that we are looking at doing, Stephanie, is making sure, if we're telling you to look at workforce satisfaction scores, that we have some kind of indication as to where you can get those, where hospitals can create that data if they don't currently have it, and then hopefully some baselines out of that. But currently, the list of indicators are just just that, things that this group come together and thought these are things that would be beneficial for hospitals, small rural hospitals as well as critical access hospitals and clinics to be thinking about, to be considering, to be efforting.
Hey, Caleb.
As far as out migration and things like that. Yes, sir.
Caleb?
Yes, sir. Go ahead.
For Stephanie's benefit and for the others, I thought I'd go ahead and just throw this in, since nobody on the phone has probably had a chance to see these yet. But the good thing about the new indicators is that they are much of that data is currently available to your hospitals and your communities. I mean, it's more, what's the word, more dynamic information that is probably easier to get and a little easier to be more current. Some of those, the hardcore, the top 10 finance indicators are slow to come, and it means that we're always in review as we look at those indicators. But a lot of the new ones are readily available and allow you to get, take a broader picture, sooner.
Thank you, sir. So having hopefully addressed, if not answered, Stephanie's question, I'd like to introduce Ralph Llewellyn from Eide Bailly. He's a partner with Eide Bailly, and he and Brian helped by participating in the summit as well as updating the manual and incorporating these new measures into the expansion of the Critical Access Hospital Finance 101 guide, which is now the Small Rural Hospital and Clinic Finance Guide. And having read through the manual a couple times with all the edits as well as the annual read and review that we do every year, I can absolutely attest to the benefits of the information in this manual. It is, I think I'm kind of happy that we took the 101 out of there because there is just a ton of information and data in there. So we'll talk about the new data that got put into there as well as the review of the 2012 indicators and then discuss some of those new 2018 key indicators. Ralph, are you unmuted?
Yeah, I believe I am. Thank you.
I hear you.
All right. So first of all, yeah, I'm really excited to get to talk about this because I've been involved with some of the rewrites in the past of the CAH Finance 101 guide. I think the name change is great. It's going to take care of addressing a larger piece of need in the rural community, not just CAH, but we're going to throw in, some rural PPS, small PPS items, as well as hitting the RHCs, which is going to be a big game changer because so many people have these in the rural setting. So we have the new data. We have the 2012 key indicator review. Basically, this is going back, looking at those top 10 that we had before, updating it for 2006 data set. That's kind of back to Jack's comment about, getting timely data. This is a little dated because it's cost reports. It takes a while to get that information released to our friends at the Flex monitoring team. And so by the time they get it out, it's, a little dated, and that's one of the frustrations there. We also have in here the 2018 key indicators for rural hospitals and clinics. We'll talk a little bit about that too. It's just going to be a little different there than what we've seen with the CAH. Can we go to the next slide? So over 20 new pages. So, we went from about 30 pages to about 50 pages in this manual. So there's a lot of new information in here. And so as you look at it, if you read it before, it's going to have a totally different feel, I think, from what you've seen in the past. There's going to be 3 sections. As Terry alluded to, we've added small rural hospitals and rural clinics. So the critical access hospital section itself, for the most part, is fairly similar to what you've seen before. We'll talk about some of the additions in the performance indicator strategies component. But as we look at the small rural hospital component, what you're going to find there is, how are they reimbursed? Because it's a totally different reimbursement model than what we see in the critical access hospitals. It talks about the financial indicators. Now, the challenge we have in the financial indicators at this time is we don't have this rich database like we get from FMT for PPS hospitals, small PPS hospitals at this time. So a lot of it's talking about trends. What direction should people be going as far as their financial indicator and those kind of components, as well as how they can affect them. How can they make them better? Some of those components in there. Talking about the cost report. Cost report doesn't have as much impact on a small rural hospital as it does with the critical access hospital, but if they have an RHC, there can be some impacts there. Same type of concepts, though, apply when we talk about revenue cycle and physician practice assessments and lean operations, etc. A lot of those same concepts that are important in the critical access hospital realm are going to be just as important and sometimes even easier to impact the bottom line in the small rural hospital. We'll also then look at the rural health clinic side. There again, we don't have the same type of indicators that we get from the FMT, but we did add some indicators that we think are really important to look at. Things like days in AR, cost per visit. What's that cost per visit? The average cost out there has been around $176. Where are they at from that perspective? Payer mix. The number of visits per provider. That's a big issue I look at when I'm working with clinics. The mix of nurse practitioners and PAs to the physician. Those that tend to have a higher mix of mid-levels oftentimes can perform better financially. You've got to have the right number of physicians in there, but you've got to have that right mix. Staffing cost per FTE and average charge per visit. Some indicators just for people to be looking at and comparing their performance. Let's also talk about how to improve their performance as we look at that, thinking about things like the cost report. And the one thing I tell people about the cost report is, you can't make any money on the cost report, but you can sure lose a lot if you don't fill it out right and get the money that you have coming to you. Talking about strategic, financial, and operational assessments, some issues on revenue cycle, similar to small rural hospitals. We'll have some commentary in there about physician assessments and what's going on in that area, as well as the benefit of CFO networks. So that kind of gives you an idea of what those sections are going to look like. A lot similar to what we had in the CAH, but just one for each area. And then this is the piece, when we get into these additional performance indicators, that really excited me about the update. And it's because when we get called in to help people look at those top 10 financial indicators, and they want to know where they're at and where they should be going and how do we make them change, that's where we got to get into these leading things. And these are the very specific types of things that we are digging into when we're on site working with providers to make sure that they're addressing. So we're going to talk about all of these, but the one thing I'll tell you is that it's really hard to find consistent data over a national basis. Some states are going to have more data than others, but some of this is difficult because it's not available consistently across the country, such as we find when we use the top 10 indicators that the FMTs pull together for us, or the FMT pulls together for us. So let's talk about market share. Market share is a huge piece when we get on site and talk to people about helping them understand, do they know their market share, do they understand it? When we start thinking about ACOs and how do we build our market share, if we're going to bring down the cost of care, we're going to reduce potentially over time volumes, we have to replace that with something. It's how do you capture your market share? It's those strategies to control out migration and other leakage in the market area. Financial, really only one new financial indicator that was in there. It's on liquidity. Some of the other indicators allude to liquidity, things like accounts receivable, days cash on hand, etc. But this one just gives us another financial indicator that was added into that group. Operational efficiency, this is definitely a challenge for all providers. This is how to staff, how to benchmark, trying to get that kind of data, these really tough decisions. I will tell you, this is the one area that if people pay attention to, is an area that can very quickly change some of those other top 10 indicators, those results that you see there. So this is a very important piece in my perspective. Looking at telehealth options, kind of goes back to Terry's comment about the average cost per clinic visit. What are we doing in that area? Workforce, talk about adequacy and then the education of it. Care management, this gets into that whole population health and those types of services that we're seeing ACO providers getting into. It's important to note that you don't have to be an ACO provider to take advantage of these, though. There are things like chronic care management, transitional care management, annual wellness visits, all of those things that if people are really paying attention here, it's actually going to increase the improvement of one of the other lead indicators we've already talked about, which is market share. Patient satisfaction goes up. We're getting more services coming in, keeping more services local. They kind of work hand in hand together as people start getting into the care management side. Quality performance, hospital compare, things like that. I mean, there's all kinds of those things that are out there, quality things that we have to report for ACOs. Definitely a great indicator of what people are doing from a quality perspective, a satisfaction perspective, etc. Community health, I think one of the things Terry talked about a little bit was the HCC scores, how it looks like we're not taking care of that difficult of patients. And we do a lot of reviews in the area of HCC, and there is a lot of opportunity for providers to improve their documentation and reporting. Sometimes the documentation is there, but the reporting isn't. Sometimes the documentation isn't there, so it doesn't allow for the reporting. But it's definitely a huge opportunity when providers start looking at how can they better relay to Medicare and eventually other payers how complex the patients are that they are seeing. I also liked in there some things that Terry talked about with the PCPs and contracts. As we look at physician contracts, that's a lot of things that we see there. Adding performance types of things, like what percentage of your patients are getting annual wellness visits, how many of your patients that are diabetic are getting diabetic self-management training, what's the percentage of patients that have an A1C below 8, or those types of indicators. Definitely a big piece that can help drive some of the other financial indicators down the road by putting those in place. And then the overarching strategies, and this talks a lot about needing to understand your data. All of these things that we've got here in these indicators really shows that we have to have a better access to more data, more timely data, and then we have to know what do we do with the data. The danger with data is that it's just data, and we haven't turned it into information and knowledge. And that's the key piece here, is you need to understand it, but you got to get it first. So a lot of things going on there, and then the ability to affect rural policy, making sure that at the federal level, the policy that's coming out makes sense for rural health. So that's kind of what you're going to see in that manual. Lots of new information. I'm sure there'll be lots of questions that come out. And by all means, if you have questions along the way, make sure that you reach out so we can help you.
Yeah, thank you, Ralph. Do we have any questions for Ralph about any of that, some of the data and expansion of the manual? So as Terry indicated, they said that the manual will be out shortly. We're just finalizing our press releases and updates to go out to everyone. It'll be live and available on the website as well as the summit findings report. But I think, as Terry indicated, this is really an expansion of what we see these 2012 initial indicators are to benefit the day-to-day operations of the hospitals. But this expansion of this manual really is, in my eyes, seen as an indicator of where we are in the healthcare landscape. Joaquina's updates talked a lot about value-based payment reform and the changes to that. So this expansion of the manual, I think, is representative and indicative of that. So everyone knows and loves Terry's shaky bridge analogy, that we were on one side of the bridge, and I think we're squarely in the middle of that bridge right now, especially with critical access hospitals, and that these payment changes are happening, and we need to be at least aware of what's going on right now and what the hospitals, communities, clinics, both critical access hospital and PPS hospitals can do to help prepare for that change. Days cash on hand is as important as it ever was, and that's why all of those indicators are still in the manual. But there are a bunch more things that hospitals need to be at least thinking about and seeing how they can strategically place themselves in a situation to be able to change and adjust their processes and policies to help ensure that they're going to continue in this new landscape.
Caleb, can I add one more piece?
Absolutely, please do. We have around 15 minutes, so I'd really like to have some discussion, some questions from the participants, and communication amongst all of us. That'd be great.
Okay. Well, the one thing I'll tell you about this manual, I like this manual so much that I right now I'm working on some presentations for some trustees in Montana, working with Jack's facilities, and this is going to be one of the pieces I'm going to make sure that is in that to tell them that this is what they need to read. I think it's a nice read from the aspect that it's not so deep that you have to have a high level of understanding of all the intricacies, but it allows you to understand these are the types of things that we should be paying attention to. So I would highly recommend that anybody that's working with providers, not just push it out to the providers, but really try to push it to the trustees too, because they really struggle in getting good education. I think this is a good read.
I agree. I think that's a really good point. We spoke a lot about that during the summit meeting, is educating the board and the community on what is going on and the difference and the change between the expectations of what a hospital was and the type of care and the way they provided care 20 years ago to what those expectations are now and what they're expected to be in 10 and 20 years from now. The community health and population health, the management of that, the out-migration. 20 years ago, it was a lot more difficult for patients to drive by a hospital, but it's not unheard of anymore. You can easily drive by even the critical access hospital. If they're not providing the care you think, the quality of care you think, or if you don't know the care that they are providing. And that's something that I remember from my time as a flex coordinator, is the community was oftentimes not aware of the care provided at the local level. Either the the acuity availability or the services or what have you. So that's a huge indicator or opportunity for the hospital to be able to be educating their community on what that hospital is and can be, and working with the community on with the local grocery stores as far as identifying healthy meal solutions for diabetic patients or heart failure patients, whatever the community is in need of. The hospital now has an identified role in helping provide that.
Now, Caleb, it's interesting you say that about the marketing component, about people knowing what you provide, because some of the most recent on-sites that I've been doing from an operations perspective, I have found huge gaps in the marketing programs. People don't know what is being provided in the communities. It's because there isn't a tie between the community health needs assessment and then to the strategic plan and then to the marketing plan. So as you look at that market share, if they don't know you're there, how are they going to come?
It's very difficult. And that, like I said, that's something that you hear quite a bit, is just, oh, well, we didn't know that hospital provided that. Hospitals close all the time because people drive by instead of receiving care that they could have received.
Yeah, let me jump, this is Terry, let me jump into that conversation as well. Kind of besides the anecdotes, and this is something Ralph and I lament together about why we can't get the hospital's attention on this, but basically we have probably done at least 150 community surveys through, we've been doing them since literally 1988 here at the center. And I can just tell you that we have rarely ever come across any hospital, and our surveys are largely very hospital-based in terms of we try to ask questions about why people leave the community, not just the public health. We ask the public health questions too, but we ask a lot of questions in that regard. And almost invariably, the public does not understand what services are at the local hospital. And it is so difficult for us to get the attention of hospital leaders on that. It just doesn't seem to make sense to them. But the data and the information is startling in terms of that. And I would add to that, Ralph, and I know you're aware of this as well, that when the ACOs, so the hospitals that are participating in the ACOs, actually get their data and information of what percentage of the potential market they can be, that they're getting. And we're not talking about heart surgery here. We're talking about basic primary care or something that might be cardiac rehab that's leaving town. I always found that they are shocked that they're getting, in many cases, less than 50% of their potential market share. And you want to comment on that, Ralph, too? I think we've got some pretty clear information about this problem. And again, if you're going to reduce your inpatient revenue, which is inevitable in these value-based models and population-based, you've got to make it up for that on the outpatient side.
Absolutely. So when you belong to these ACOs, one of the things that you get, the information that Terry's alluding to, is you get all the claims data when those patients go somewhere else, wherever they go. So you start to figure out what are they getting from you versus what are they spending when they go elsewhere. And you can drill that down to the service line and which facilities and everything else. And that is the really telling piece. When you find out that, you're getting 20% of one DRG and 80% of it's leaving. It's like, well, why is 80% of it leaving? Because you can do it, obviously. You've done it 20% of the time. Where's the rest of it going? You start drilling it down. You start figuring out, is it awareness? Is it a perception issue? Is it a true quality issue? Is it, what is the driver? Is it an access? Just because we're open 8 to 5 doesn't mean we have access, because people work 8 to 5. Where are they going for the clinic visits? All those kinds of pieces. When they get that information, it's the first time that they struggle in trying to deny it, because the facts are there. Right now, they really think they're getting more than what they're getting. When they see the reality, it's a big eye-opener.
And Ralph, another piece of information they get is they get information on, kind of what is the cost and the quality, maybe not the quality, but the cost certainly. So these referrals are being made. Usually referrals from rural hospitals are made without any real indication. I don't know what it costs to, I'm sending this patient to, let's take, Billings, and how much is it costing, because that hasn't been relevant in the past. But once you start getting into an accountable care organization, you have to be concerned about that, because we just had a report here in Minnesota that came out from the Department of Health about the huge variation in the amount of cost within our hospitals in Minnesota. And what they found is that some of our hospitals are charging 3 times as much for the same procedure as other hospitals. And when I was asked about it, I said this is pretty complex. It's not as straightforward as that, but still it indicates that if I've been referring my patient to referral center A, and I now see that referral center A is providing much costlier treatment, I may very well change my referral patterns. And in fact, where we get into problems, I think, in rural hospitals is I've had physicians talk to me about the fact that since they are now incentivized through MACRA and MIPS to send their patients to high quality, lower reasonable cost centers, several physicians have indicated that could really be a problem for us. I might send it to a different hospital than my local hospital here. So that new access to information is going to have, I think, some pretty significant impact on our hospitals.
Now, people in the past used to send people based on their relationship and their friendship. Now they get the data. They either work on the discussion with that person they have the relationship with, or they go find a new one.
And Ralph, is there any data or anecdotal data or information anyway about which patients are more likely to travel, Medicare patients versus private payer patients?
Anecdotally, I would say private pay patients are traveling more. And the reason I say this is I think they start to travel more because of that comment I made about access to care. When you think about what those